Okay, so I'm Kate Gill, and I'm the president and founder of the Australian charity FND Australia Support Services, and also a senior occupational therapist and director of the FND Clinic. I'm engaged in many research projects in FND, mental health, etc., and work as a consumer researcher in a number of projects. So I'm going to be talking today about FND and NDIS. So I'm an occupational therapist, so nothing I say is to be used as medical evidence. Please see a medical practitioner for any medical concerns related to your health. I can talk as an OT, but not qualified to comment on areas that are not OT. So today I'm looking at NDIS because this is a question that we get in the FND community probably on a daily basis. Are people with FND eligible for NDIS? How do I apply? What do I need? How does the NDIS work? So I thought it would be useful to do a talk that would benefit many people in terms of how do I access NDIS if my disability needs associated with FND meets the requirements. So what are the requirements? So the NDIS is for people with disability to get support if they have substantial disability needs. So the NDIS is for people aged under 65. They need to be Australian citizens. If people are accessing compensation schemes, maybe work cover, CTP, etc., that may impact NDIS funded support. So it's just something to be aware of if you're accessing different insurance schemes, in that it may impact your support or your funding. And NDIS is for people who have a disability that is permanent and fully treated, and they need specific supports to function in daily life. So not everyone with a disability or a health condition, including FND, will be eligible for NDIS. So it's for people who have a disability that's caused by permanent impairment, which may be neurological or various other reasons. So is FND a disability that is eligible for NDIS? Well, it does depend. A disability attributed to a neurological condition, section 24(1)(a). So FND, it is a very complex condition. The symptoms are neurological and the symptoms are very disabling. It's tricky because outcomes vary. So there's not a one size fits all for FND. Some people do recover or do quite well and live, a reasonable life with FND, but not everyone does. Some people do go on to have quite a serious and profound disability. So long-term follow-up studies that a large majority of people do remain quite disabled and symptomatic over time. So the first criteria to meet with NDIS is permanence. So a permanent disability is the loss of ability to perform activities from an impairment. So this impairment, neurological, etc. So that's section 24(1)(a). So with FND, we have disabling symptoms, which include abnormal movement, gait disorder, etc., fatigue, chronic pain, seizure-like episodes, problems for some people with vision loss, speech and swallowing. So very, very disabling symptoms which can impact on daily life. But one thing we do know about FND is it is generally variable. So some people may have continuous symptoms. For example, they may always be in a wheelchair, and that is their disability with FND. But for other people, they're having variability in function. So they'll have periods where they say completely can't walk. They may be able to walk abnormally. The gait may return. They may be wheelchair bound. The walking may improve. They then may lose partial function. So one of the issues with FND are intermittent symptoms and variability of function for many who live with FND. Now, NDIS does accept conditions that are episodic. So you might have periods of normal function, but overall, if you require support in daily life because of abnormal function, you may still meet NDIS criteria for permanent disability. So we often see for people with FND, their function can vary quite a lot. We can have people who are restricted to a bed or a wheelchair, people who require mobility aids. And other days, people may be able to have quite normal function, and their function can vary across this spectrum, hopefully not up to 10. But their function can vary across this scale. So it is different to other neurological conditions, for example, multiple sclerosis, where there may be a progressive decline in function. So is FND a permanent disability? Well, that depends. According to the DSM classification for FND, it is an acute episode if the symptoms are present for less than 6 months, but it becomes persistent if the symptoms are occurring for 6 months or more. And people may actually have both. They may have, for example, a mobility impairment, which they've had for years, but then they may have an acute episode, for example, speech loss, which is acute and less than 6 months. But have they had symptoms of FND for longer than 6 months? And when we see people wanting reports for NDIS, if they are within 6 months of the onset of FND symptoms, we won't do an NDIS application because they're still in this acute episode. And hopefully, with the right care and treatment, the person may improve. But it's when people have had these persistent disabling symptoms for quite a while, and by definition, for longer than 6 months, that we may start looking at NDIS. So disability with FND is on a par with MS. There are talks that for some people, it may be potentially a reversible source of disability, but maybe not for everyone. For a number of people, it's been found that for people who might have had a longer delay to diagnosis, the people who have had the condition for a while, the prognosis is actually quite poor, with 50 to 90% of people experiencing ongoing symptoms, and often the symptoms are becoming progressively worse. And studies have found that at long-term follow-up, for example, at 12 years, many people are symptomatic, distressed, and disabled, with, again, similar levels of disability compared to multiple sclerosis. Similarly, it's been found for adults with functional seizures, the outcome is generally poor, and the quality of life is worse than people who are dealing with epilepsy. So things that may predict a more favourable prognosis is younger age, acute onset, a very clear precipitating event that led to the onset of FND symptoms, previously being in good health and not having any other physical health, mental health comorbidities, access to FND treatment, and a really clear explanation of the diagnosis. Those who don't tend to do so well are those who've had it for longer, those who don't fully recover. They have repeated episodes and maybe don't fully recover in between episodes. People who have unfortunately had negative interactions, going for a while, not being believed, not getting a diagnosis quickly, and the failure to offer appropriate treatment or experiencing secondary harm and complications, or even being misdiagnosed, can be another factor in poor prognosis. So in order to meet the criteria for NDIS, we need to know, are the impairments that arise from the disability permanent? So this is section 24(1)(b) of the current NDIS Act. So the impairment may be considered permanent or likely to be permanent if there are no known, available and appropriate evidence-based treatment that would likely remedy the impairment, or the person has accessed treatment, but it has not led to a substantial improvement in their functional capacity, or there is no treatment available to the person that would remedy their impairment. So NDIS will need evidence that the person is fully diagnosed and fully treated. So all treatment options have been exhausted and have been unsuccessful. The supporting evidence needs to outline the degree of success with treatment. So the person engaged in this treatment for this period of time with this frequency, did they improve substantially? Did they improve a little? Did they not improve at all? Or did the treatment make them worse? And then they need documentation that the impairment is likely to be permanent and that the current baseline function will not improve. It's a permanent impairment associated with this permanent disability. So information about current treatment will be viewed by the NDIS as the person not being fully treated. So people might say, I'm accessing psychology, I'm still doing weekly or monthly physio, etc. So if that is ongoing, NDIS will say, come back to us when you finish treatment. So if the person happens to be accessing care, just as part of ongoing management, which a number of people do. So for example, with physio, if the person has physical impairments associated with the disability, e.g. FND, and they're not able to engage in regular exercise, they might be accessing specific physio related to the disability in order to maintain their current level of function. So that would be part of managing the person's disability, maintaining capacity, or potentially improving the person's capacity to manage the disability. But the person will still have the disability. So who might you be getting evidence from? With FND, of course, the symptoms for FND are often, they can be quite variable. So who's part of one person's treatment team may be different to another person's treatment team because they have different symptoms. So for some people, getting evidence from the neurologist that they've accessed, or evidence-based and relevant treatment that they are fully diagnosed, that the condition is likely to be permanent. If the person has movement problems, they are likely to require evidence from the physiotherapist that they have accessed or physiotherapy treatment, and ongoing physio will not remedy their impairments. It may be an OT for people with speech and swallowing disorders. It might be a speech pathologist. A psychologist might be important for some people, or a psychiatrist might be important for other people, depending on the person's symptoms and the overall presenting picture, what else that the person is dealing with. So information about current treatment is regarded as not being fully treated. So if you meet permanent disability, the NDIS will then go to the next stage around assessing functional capacity. So having an OT functional capacity assessment is a very important part of the evidence in NDIS applications. So the person must have a substantially reduced functional capacity. So this means that the individual, because of their permanent impairment, cannot undertake tasks in one or more of 6 particular life domains without either support from another individual or a prescribed piece of adaptive equipment technology. So things like prescription glasses, a walking stick, maybe a four-wheel walker, that may not be enough to have a substantially reduced functional capacity. But if the person has been prescribed by a physio or an OT a wheelchair to meet their mobility needs, that may be regarded as they're dependent on adaptive equipment. So a person doesn't have to have substantially reduced functional impairment in all 6 domains, but at least one of the domains needs to be substantially impacted. And doing things differently, if something causes you pain, e.g. hanging out the washing, is painful, it's a slow task, it's difficult, that may not be regarded as a substantially reduced functional impact. It needs to be the person cannot hang out the washing, they cannot lift their arms up, therefore they cannot wash their hair, they cannot hang out the washing. They need support of someone to wash their hair for them, to hang out the washing, etc. Increased time and effort is not substantially reduced. Substantially reduced means I am dependent on support to do this activity because of my permanent impairment, I cannot do it. Or I am dependent on prescribed adaptive assistive technology in order to, say, mobilize. So it's around relating the symptoms. What is the functional impact, the impairment of this symptom in the particular 6 domains of relevance to NDIS, and documenting what is the support required to do this task due to the permanent impairments that the person experiences. So the 6 domains of relevance are self-care, so that can be feeding, it can be showering, toileting, continence, etc., communication, talking, listening, interaction. Self-management includes your day-to-day tasks, so tasks around the home, cleaning, laundry, financial management, paying bills, making decisions, learning a person's capacity to learn, take in information, remember information, process and organize information. A person's social interaction, so making and keeping friends, behaving within normal limits, coping with feelings and emotions, and of course, mobility. So the different domains, these are the areas that you'd want to provide evidence on. How does that person's impairment affect, for example, their mobility? So can they use public transport? Can they leave the house and access a community independently? Can they move around the house? Can they go into the community? So evidence for each of these areas needs to be provided, for example, in a functional capacity assessment. So this substantially reduced functional capacity is providing evidence that the person requires assistance, which can include physical assistance, for example, physical assistance in transferring from wheelchair to bed. It can include supervision. For example, my partner needs to be supervised when having a shower because they may fall, they may have a seizure, or it may be prompting. I have to prompt my partner to take medication. I have to prompt my partner to eat, to go to the toilet, because they won't remember. Or does the person require this assistive technology to do an activity? And clinicians can provide supporting evidence using various clinical assessment tools that measures the person's level of impairment and the impact of the level of impairment on function. Other supporting evidence can be a carer's impact statement. So we know from research that we did with support from the National Mental Health Commission that carers' wellbeing in FND, so carers looking after a loved one with FND, is substantially affected. So they may be affected physically, for example, trying to lift a wheelchair. They may be affected emotionally, like this carer burden that people can develop over time because of the seriousness of the condition, the impact, watching a loved one in so much pain, being so symptomatic. Carers also experience significant financial burden. They may not be able to continue in their work role. They also experience loss, but lots of levels of loss at different levels when caring for a person with FND. So a carer's impact statement can provide additional evidence of support needs. For example, I can no longer work because I need to help with my child, my partner, getting out of bed, showering, dressing, feeding, remembering to take medication. It can provide evidence of the impact of the impairments on function. Because of my partner's tremors, they can no longer feed themselves because their hand is shaking and they're making a mess of the cereal. So I have to physically feed my partner. The carer's impact statement can talk about the risk to the person with FND, but also the risk to the carer. For example, the carer, I have a back injury. I cannot lift the wheelchair into the car. So therefore, I cannot take my loved one with FND to the shops because I can't get the wheelchair into the car. It can identify levels of carer burnout, the risks of carer burnout, the sustainability of informal supports. I'm not going to be around forever to look after my loved one. What's going to happen to my loved one, my child, etc., once I pass away? And as a result of all of this, it provides further evidence of what is the need for formal supports. So having a carer's impact statement is another level, not enough, but another level of supporting evidence for NDIS. The next criteria, 24(1)D for NDIS, is that the disability affects the person's capacity for social or economic participation. So because of this disability, they had to leave their full-time job. So they're no longer able to work in the same manner. They have to have modifications at work. I can now only do 2 hours at work and I do it from home. I can't go into the office. I require modifications. It can also, for children, it looks at children attending school. So my child can only go to school for 2 lessons because they're having seizures after a couple of hours at school and they get sent home. So that will be your productivity, so your economic participation, which includes your learning, also university. Also around your social participation. So because of my disability, I can't socialize with my friends. I can no longer dance. And that used to be my favorite hobby. I can no longer go and play sport with my peers. I can't go out for coffee because I can't leave the home, or I can't interact because the environment in the coffee shop's too noisy. I'm experiencing seizures, so I can't go out and maintain my friendships. And the last criteria for access is that this permanent disability means that the person is likely to require the support of NDIS for their lifetime, and that the support required, the support that the person's looking for, is most appropriately provided by NDIS and not other services, for example, health or education. So when providing evidence to the NDIS, the documentation, the evidence is really important. Everything submitted to the NDIS should be specifically tailored to the NDIS Access Criteria, which is at section 24, 1A to E that I've just mentioned. The evidence should be recent. So for example, like physio reports shouldn't be, 5 years old. It should be within the 6 months. The treating professional who provides the evidence should be the most appropriate person to provide the evidence of this primary disability and have treated you for a significant period of time. So you can't just turn up to a physio and go, I have FND, write me a letter. That clinician needs to know, develop a relationship with the person, see their disability over a period of time. There's also a number of red flags and words that shouldn't be used. So with treatment is past, I am fully treated. So the person must be fully treated pre-NDIS application. NDIS does not fund treatment. We've had a number of people come to us and say, I need the NDIS for treatment. I'm not going to get better without treatment. So NDIS doesn't fund treatment. If you can't afford treatment, NDIS does not address that gap. NDIS does not address the gap in the health system. For example, a chronic disease management plan or a mental health care plan. There's often quite a substantial gap between what Medicare pays and what the person has to pay. They don't fund that gap. Generally, if something is covered by Medicare rebate, it's not covered under NDIS. Pain management, a bit tricky, but is generally not covered under NDIS. The impairments are covered, not the pain. If a person has a psychosocial disability, as well as FND, alongside FND, we need to talk about the psychological supports addressing the psychosocial disability. It's not mental health treatment. The person is fully treated prior to accessing NDIS. So the reports need to talk about the disability impairments. It's not about a medical condition or a health condition. It's about the impairments. Some other red flags is this person will benefit from, or this person requires the support of NDIS and they will benefit from physio and psychology. That will be perceived as they're not fully treated, they will benefit, i.e. improve, therefore their disability is not permanent. This person requires, for example, physio treatment. If they require physio treatment, they're not fully treated. So again, they might require ongoing physio to manage the effect of the disability or to reduce functional decline. So words really do matter. With the access request form, so people fill in, it's this substantial document, it's about 25 pages, and there are tick boxes in there. And one of the questions is the impairment currently being treated? Now, many people will be on ongoing medication. They might see a neurologist once a year. They might see a psychiatrist once a year or more frequently. They might have weekly psychology to help them manage in daily life. But that is all part of management. The person has accessed all treatment that will remedy the impairment available to them. Ongoing care is about managing the disability. It's not about treatment and recovery. So this can be a bit of a tick box thing that leads to problems, because a lot of people say, yes, I'm being treated. I see a neurologist once a year for ongoing management. That's management. So at this point, the person needs to submit the access request form with evidence, supporting evidence that meet the NDIS eligibility criteria. At this point, NDIS may accept they meet the disability requirements, or they may deny it. If it's denied, the person can have an internal review. If that supports the original decision, they may go to a tribunal to have it reviewed. This can take a while. It's not a quick process. Sometimes a decline might be quick, But trying to re-articulate the evidence to NDIS does take time for a number of people. Once they're accepted onto the scheme, the person has a planning meeting. So they'll meet with an NDIS planner or maybe a local area coordinator. They will look at what are the goals that the person has and how does their goals meet the criteria of funding for reasonable and necessary under NDIS. So again, if the person's not satisfied with the level of funding, with the level of support, that can be reviewed. It can go to the tribunal. In the meantime, the person can utilise their plan in accordance with the legislation and accessing support that are in line with their NDIS plan and keeping records. And at some point, the plan may be reviewed. This can go through another planning meeting. And again, of course, there are the options of reviews at each of these points. So NDIS supports must help the person pursue their goals, and they're the NDIS goals. It should be designed to increase the person's level of independence, their community and or capacity to participate in their workplace, and the capacity to take part in the community. So the NDIS goals is based, well, the NDIS funding is based around the NDIS goals. So all the goals should be utilised, and the goals should address what are the person's needs in relation to the NDIS funding. So it's not about, my bucket list. It's not about, my bucket list is to go to Egypt and see the pyramids. If that person wants to do that, they may require support, but it's around what are the supports that they need for daily living. So it might be, I require support to assist me in my capacity to manage the home, so shopping, cleaning. I require support to participate in my community groups. I require therapies to maintain or improve my functional capacity to mobilise, etc. I require therapies to help me manage my physical health. I require access to assistive technology to build my independence in accessing the community. I require home modifications to improve my independence, say in showering, for example, a shower bathroom modification. And the plan will be built around those goals and the support needs in your various capacities, with therapies under capacity building. So that's your physio, psychology, OT, speech, etc. And your core supports for your daily living kind of activities, supports around the home, supports to access the communities. The person may receive support coordination if they have fairly complex needs and they require support in terms of managing their access to services. Consumables, the person may require because of their disability. They might have incontinence issues. They might require cognitive aids, personal alarms, false alarms, and they may require a capital budget for assistive technology, but this will require, depending on the cost and the risk of the particular assistive technology and home modifications, they will require additional formal reports. So the reasonable and necessary criteria is based on how the person can spend their funds. So they can only spend their funds on services or items if that item or service meets all the reasonable and necessary criteria. So the current reasonable and necessary criteria is that it's related to the NDIS goal, that it may facilitate social and economic participation, that it's value for money. So that means that the lowest cost item that meets the person's specific disability needs is what will be funded. If the person wants something for aesthetic reasons, they pay the difference. For example, a blue wheelchair is a certain cost, but a pink wheelchair is $200 more. That person would pay that $200. So it's got to be value for money. The service or the item must be effective and beneficial. So evidence-based practice, not some new idea that the person thinks may be useful, but there's no evidence for it. The support should be most appropriately funded by NDIS and not by the family. So for example, if it's a child, they may say, this is parental responsibility. Or is that service that the person is requesting, is that more appropriately provided by another service system, for example, the health system or the education system? The item needs to not cause harm to the participant or others and not duplicate another service or system of supports. So NDIS is not always smooth sailing. There are a lot of frustrations that people experience with NDIS. Sometimes people feel that they're drowning in red tape, or certainly clinicians might feel that they're drowning in red tape. The participant or the person trying to access NDIS, and sometimes the therapist can feel like they're dragging boulders uphill, trying to get the NDIS to listen to them, to read the report. Sometimes you'll find the person clearly meets the eligibility criteria, but it was still denied. The evidence was provided, but the report or the content was not acknowledged, ignored, etc. There may be repeated requests for more evidence when the evidence has already been provided. There are delays, there are denials. People are often not given enough funding, especially for therapies. And sometimes we see that the NDIS wants a support worker to do everything. So a physiotherapist can have 4 hours to design a home exercise program that the support worker can do with the person each week. And that may not be appropriate. That may lead to a level of risk. A support worker has not done the years of training at university to know how to appropriately meet that person's disability needs, and it could cause harm. So definitely NDIS is certainly a challenging area, and while some people with FND may meet all the eligibility criteria for NDIS, it is definitely not always smooth sailing. So if people have any further questions, I am happy to be emailed. I can be contacted by the website or by the email address. Thank you.